A very good evening to one and all present here. I, Dr. Komal Lalwani, on behalf of Nationwide Quality of Care Network, welcome you all to today's Community of Practice session on the human side of change by Mr. Vincent Baxter. Now, I request Dr. Kedar Swaleshwar to introduce our speaker of the day. Dr. Kedar is a chief neonatologist at Deodari Children's Hospital, Aurangabad. He is an ex-associate professor at GMC Aurangabad. He is a national mentor for Lakshya program by Government of India. He is a national faculty at NRP India and national faculty and member, ex-committee development and supervisor, Supportive Care Foundation for Newborn and Children India. He is a founding member and national coach at Nationwide Quality of Care Network India. He is a national instructor at FBNC India and national faculty at NEST India. Over to you, sir.
Thank you, Kamal. So friends, a warm welcome to all of you for this important webinar, which will give us a different insight to what we have been actually training most of you regarding quality improvement methodology. So quality improvement methodology has given us a theoretical framework, and we have all applied technical skills and understood variations. We have studied the system. So we have determined the best evidence-based intervention, that is the what, and implementation strategies, that is the how, to achieve the desired outcomes. But friends, all of you will agree that despite using the this framework, yet all of us, the healthcare improvers worldwide, still struggle with the adaptive side of the change, and which relates to the unleashing the power of the people, that is the who, and their motivations, that is the why, to advance and sustain the improvement. Sustainability has always been challenging and will remain challenging until and unless we actually address the human side of change. So while teaching the fishbone, we have always told you that focus on processes and place rather than people. That is good. These tools obviously will give us the desired result. But when it comes to sustaining, all of us now have understood that it is people need to change their behaviors and to sustain the improvement. And we have all learned about the Deming philosophy. We have also learned about the Rogers innovation curve. We know that now from early innovators to early adopters to early majority. So we need to cross that chasm and have the early majority on our side so that we can sustain the change. So building on that legacy, we need to now focus on the human side of change, which increases the likelihood that our efforts to improve the health and healthcare will succeed and will be sustained over time. And to understand this human side of change, we have a passionate faculty with us today, Vincent Baxter, who is an improvement manager with emergency care improvement support team, which is a part of NHS England and improvement. So his role there currently is he works with the health and social care system, which supports the organizations to adapt to known good practices in a consistent and accessible way, so as to improve the most urgent and emergency care for the patients. And his basic clinical background is from nursing, clinical nursing. And he has been an operational level manager in the acute hospital settings, as well as in the communities and mental health settings. So he's very passionate about improvement and change, and the value of the delivery of safe and high quality and compassionate care. So his educational background consists of, he has got a diploma in higher education in Central England. He is a Bachelor of Science in, he has got an award in supervision and management. So he's done MBA so in 2011. So a wonderful background on top of his passion for improvement. So, friends, without taking much time, I will hand over the proceedings to Vince. Vince, you can start your presentation. Thank you for joining us.
Thank you very much, and thank you very much for that introduction. What I'll do, I'll start by sharing my screen, and hopefully everyone can see that. Not sure if you can see that at the moment. Hopefully you can see my screen now.
No, not yet. We are unable to see the screen. Are you able to share your presentation?
Yes, I've got it up.
Share screen.
My computer doesn't want to play ball with it.
Technological glitches.
Yeah.
So please check now. Now you'll be able to share the screen.
Yeah, it's just not wanting to play ball for some reason. Let me just try that again. Okay. Let's see if that'll do it.
You need to log out and log in again.
Yeah. See if it'll do it.
What does the screen says?
It's just asking me to grant access for some reason.
Komal, access has been granted.
Yes, sir.
Yeah, I think it's my firewall that's trying to stop it, actually.
Sir, can you mail your presentation to the NQSN office? I'll immediately share it.
Yes, I can. Yeah, that might be just easier rather than me trying to just struggle with
Yes, sir.
just Could you just give me the email address and it'll
I
pop
have
up.
texted you, sir, in the chat section. Yes.
Okay, that's great. I'll just ping that over to you now.
So till the time the presentation is getting shared, I will just request all the participants, you can type your queries in the chat box or Q&A box. So what are the challenges you think that you are facing in adaptive challenges you are facing in your day-to-day improvement work, so that you can share with us. So in QI, we say there are two types of challenges we face. One is a technical challenge that we can tackle with the tools of point of care of quality improvement. Whereas the adaptive, that is the behavioral challenges, which needs a different method to tackle. So you can post in the chat box the adaptive challenges or the behavioral challenges which you are facing in day-to-day practice.
Okay, so that should be on its way to you.
Komal, you can check the inbox.
I'm checking, sir.
Mail sent.
There you go. It's definitely sent from my end. I think it's just a firewall on my computer just doesn't like it.
You can just firewall. You can just stop work temporarily.
So, sir, we have one question in the chat section. What is the average duration of forgetfulness of skills taught?
If you have just attended a class, it is few hours. If you have written it down, maybe few days. But if you have practiced it, then probably it is for quite a long time you can retain it and again recall it. So actually there was a famous slide I had, but I don't know if I'll find it out. I will post it in the groups later on again. So you need to practice regularly, frequently, so that the skills are not forgotten.
So hopefully my presentation should have come through.
So we have not received it yet.
Refresh, you can refresh and check.
Just check my message. Yes, it's definitely gone.
Have you copied it to me also?
I'm just going to leave the meeting and just rejoin to see whether that'll do it.
Yeah, log out and log in, you can do that.
Okay, let's see if it'll share. Hopefully,
Yes.
that
Yes.
has worked. Right, there you go. Okay, we conquered the technology. Apologies for that. It's just these NHS computers. They kind of got firewalls on them. They just kind of block stuff they don't like, but it's a bit random. So okay, I shall begin. So as Kadar said, my name's Vince Baxter. I'm an improvement manager and have a clinical background in nursing. And I work for NHS England and Improvement, which is the body within the NHS in England that's responsible for transformation and service improvement. So the title of my presentation today is The Human Side of Change. And I'm going to talk about three things. I'm going to start by discussing what we know about change. Then I'm going to go on to talk about change and quality improvement. And then I'm going to finish off by just discussing how the human side of change and quality improvement link together. So, change. 70% of change fails. Or does it? Is this 70% that you can find by putting into Google search, look at any literature? Is it a myth or is it actual reality? The 70% failure rate was first defined in a Harvard Business article back in 1995 by Professor John Cotter. However, rather than quote studies, he noted from observations of over 100 companies that they had varying degrees of success in implementing change. He was circumspect about the success and failure rates. However, despite this, other sources have quoted this figure, and they've included academics, consulting firms, but with no evidence to support their claims. So, is the 70% failure rate actually fact, or is it a myth? Is it simply a descriptive observation that has been widely misrepresented? Any peer-reviewed publications on the research that led to this 70% figure are really hard to find. So I'll leave it up to you as to what your thoughts are in terms of whether that is fact or whether it's a myth. However, the reasons behind why change fails have been studied quite a lot, and there's a lot of evidence out there looking at why transformational change and project outcomes fail. Many of these studies cite similar reasons. And there's a couple here that I'm going to pick up today as I go through the talk. And this is around the unpredictability of people and culture. So we know why change fails. What are the solutions? Well, there are many change management professionals, experts, and consulting firms out there that offer fixes. And all these are in very similar ways, and they tend to follow a linear pattern and are very plan driven. However, as we all know, change isn't linear and it isn't governed by planning alone. Organizations today, and particularly healthcare organizations, are very complex. So is a binary success or failure label too simplistic to measure? I would suggest that success or failure isn't binary because the definition of success is questionable. A lot of research defines success as meeting expectations, benefits realization, delivering the project in full, on time and on budget. However, I would suggest that real success is about people using the new technology, the new policies, and adopting new behaviours, and that business outcomes have changed for the better. Also, change success is very rarely absolute because, as we all know, things change during the course of an initiative. However, there's often unrealistic expectations, particularly amongst senior people within organisations, around what change can deliver. And this then tends to lead to change being labelled as a failure, an absolute, when often there is success there. It's just that sometimes we don't see it or we don't understand it. So I think one of the important things, and certainly one of the key things in my role, is very much managing expectations around change. But we do know some things about change. We know that it can't be predicted, and we know that you can reduce the threat of change failing by involving people. And that's really what I want to sort of talk about this afternoon. So change is about people. So what about change and quality improvement? So as quality improvers, we know that all improvement requires change, but not every change is an improvement. The ability to develop, test, and implement change is essential for continuous improvement. And when it comes to quality improvement, we very often start with change concepts, general notions or approaches to change used to develop specific change ideas that may lead to an improvement. So do we want to reduce variability in a process? Do we want to eliminate waste from a process? Do we want to improve workflow, patient flow through hospitals? So these change concepts very often provide a starting point for our quality improvement journey. We combine these with subject matter expertise, and this leads to the generation of ideas for testing change. Once we've done that, we use improvement methodology and science to begin to implement the change. We use tools such as the model for improvement so that we can test changes on a small scale prior to adopting them more widely if they're successful. So is quality improvement all about methodology and science? Well, partly. However, quality improvement is as much an art as it is a science. And this is where the human side of quality improvement comes in. So when we think about the human side of quality improvement, we think about what are termed softer skills. And these are required as much as the understanding of quality improvement methodology and science. Softer skills comprise of a number of things. Leadership. Change requires leaders to articulate a vision, build relationships, allocate and prioritize resources. Leaders need to develop a culture of process improvement by demonstrating their commitment to quality improvement. Leaders can also come from anywhere. Leadership is not the sole preserve of those informal leadership roles. And I'll come on to talk about that a little bit more in a moment. Building teams. Successful and sustainable quality improvement requires a capable team who have clearly defined roles, the right resources, and a shared purpose. And again, this is something I'm going to explore a little bit more in a moment. And probably one of the most important elements of a team is equality among team members. And this is really important if a team is going to be successful. Culture. I mentioned that earlier as one of the reasons why quality improvements or change often fails. Culture. If a favourable culture for change is not present, then even the best improvement efforts will fail. For change to succeed, the prevailing culture must foster openness, collaboration, teamwork, learning, and quality improvement. A good example of this is the translation of knowledge into practice. Research has shown that a clinician's perception that evidence is available, applicable, and adaptable will very often be influenced largely by the prevailing culture in their practice. Context. There are two primary ways in which context can influence quality improvement, and when it comes to this human side. The first one, as I've already mentioned, is culture. The second is the environment or context a particular change is being implemented. Evidence suggests that when innovations are designed for and adopted to a particular context, they're more likely to be successfully implemented. Context considerations are particularly relevant when scaling up or spreading change. And a really good example of that from here in England is a few years ago, within a particular inner city NHS hospital, they discovered that a large percentage of the local population were using the hospital to access primary care. And the reason for this was the demographic in the local area. And that demographic was made up of a large group of people who had traditionally accessed primary care through hospitals. At the time, the chief executive of that hospital moved to a very senior role within my organisation, NHS England and Improvement. And they saw that an answer to reducing some of the pressure that emergency departments were facing was to have general practitioners based at hospitals, and that when patients presented, that those that didn't require an emergency care intervention could be what was called streamed off to general practice. All chief executives of NHS acute hospitals in England were written to and asked to implement this process, and money was made available for it to happen. As a team within NHS England that are responsible for supporting change and transformation, we became involved in this process. One of the things that we heard going around, though, was that in more rural areas where the demographic was different, patients didn't seek to access primary care services through attendance at hospital. They would go to their general practitioners. So what we found was that a lot of hospitals were employing and spending money, and actually there was a lot of resource that wasn't being used or used effectively. And this became very clear that in one particular area, because of the demographic, this change is very effective, but in other areas of the country, it wasn't. So hopefully that's a reasonable example of highlighting how important context is when you're trying to implement change. Co-production is another key area, and the final one I just want to pick up here. Patients, families and their carers are central to the work carried out in healthcare. Therefore, it's vital that they are involved in quality improvement change initiatives. After all, patients may define quality and successful change differently from clinicians and managers, and it's always interesting when you sit down with a group of patient representatives to kind of hear their views. Over here in England, we've just run a collaborative using the Institute for Healthcare Improvement's Breakthrough Series methodology, focusing on improving ward rounds within acute hospitals. And this was off the back of a national report that was produced with input from various professional bodies, but also the National Patient and Carer Network. And it was very interesting working with them to deliver the collaborative, to see how different their views were from us seasoned healthcare professionals. Co-production is applicable to change in any context, as those in receipt of services, goods, etc., are the ones who experience the end product. So including them in any change is vital if that change is to be successful. So I've talked about some of the softer skills in relation to the human side of change, but there are other things. There are other things that are involved in the human side of change. One of these is around agency. Agency is very much about change agents, so people who have the skills, the confidence, the power, and the passion to deliver change, coming together with similar individuals to really push boundaries in terms of what's possible and to make change happen more quickly. There are a number of ways that you can build change agency, and I'm not going to go through all of these here, but what I am going to pick up in a moment is around storytelling, because that's really, really powerful when it comes to change. Now, these lovely sketch notes that I've just been showing, and the real experts around agency are some colleagues of ours within NHS England and Improvement, called the NHS Horizons team. They've got a really good website. I've put that up there, and hopefully the presentation comes through and can be shared around so you can access that. And they run once a year, they run a really, really good program over 5 weeks called the School for Change Agents. That is accessed by people all over the world. I did it a few years ago, and there were people on there from Australia, from Canada, from the United States, from the Middle East. So I would really recommend, if you want to know more about change and change agency, is kind of have a look at NHS Horizons. What can change agents achieve? They can achieve huge amounts, and this is really getting to the heart of the human side of change. Kate Granger was an NHS doctor who was diagnosed with cancer, and unfortunately she died a few years ago. But her experiences of the other side of NHS care, being a patient, really drove a campaign that has taken off and has been adopted across the NHS called Hello, My Name Is. And this has very much come from Kate's experience as a patient, where she felt that she was obviously having some kind of very intimate interactions with carers and healthcare professionals, but people weren't introducing themselves. So she started this campaign called Hello, My Name Is, and it has really took off. And there are, if you walk into any NHS facility today, you will see people wearing badges with Hello, My Name Is. It is on email signatures. It's a really good example of how one person really drove some major change. MPJ paralysis is another movement that was started by a good friend of ours, a guy called Professor Brian Dolan. And this is very much focused on about getting patients up, dressed and moving. And this is very much based on evidence that shows that particularly for older patients, that they can decondition in hospital, and as a consequence of that, it's very much more difficult to discharge them or get them back to where they were prior to their admission to hospital. This is a change that had no project plans, no formal mandates. It was just something that took off. It was very big on social media and actually developed into a worldwide movement. And I think next month in July, it's either going to be the 3rd or 4th worldwide NPJ paralysis conference. And that is kind of something that's been running virtually since about 2018, 2019. And the final picture there is something called, it was called Pimp My Zimmer. So over here in England, these are walking frames and they're referred to as Zimmer frames. And this started in one nursing home because it was found that older residents weren't using their walking frames, and as a consequence, they were getting a lot of falls. However, by decorating walking frames, it really encouraged people to use them. And this took off across the country and was adopted by many, many nursing homes. And actually, there's some research evidence now to show that this has actually reduced falls in nursing homes. So I suppose the point I'm trying to make here is that individuals and individual change initiatives can really scale up and make a real difference to the lives of patients. The other thing is permission. Certainly, we go around in the role that I do, and we come across a lot of frontline clinicians, doctors, nurses, allied health professionals who very often don't feel they've got the permission to make changes, which is a real shame, because evidence shows that change, particularly in healthcare, is more likely to succeed when healthcare professionals have the opportunity to influence the change, they feel prepared for change and recognise its value, including the perceived benefits for patients. Very often, the answers to some of the most trickiest questions lie with the staff who deliver services on a day-to-day basis. And what we do know is that when people feel they have permission to make change, change happens because they invest in the change. And going back to the Horizons team, one of the things that I learned from the School of Change Agents was we don't really want people to invest in change. We don't really want people to buy into change. What we want is we want people to invest in change, because if you invest in something, you are more likely to make it a success than try to buy into something that somebody's selling you. If you're a leader when it comes to change, think like a farmer rather than a firefighter. Don't rush around trying to kind of drive lots and lots of different changes through and then just throwing them to one side when they don't seem to happen. Thinking like a farmer means supporting those who are delivering the change. And it also means creating the environment and the conditions for change to flourish. So removing obstacles, providing that motivation, and not being too quick to see change as a failure, as I was saying earlier. And storytelling. This was something that came very, very strongly through in terms of change agency. Certainly the NPJ paralysis had some very, very strong stories, and they were turned into videos, and they really told some kind of very heart-rending, compelling stories about people. Why is this important, particularly for leaders and for organizations? Well, usually we start with the what, not the why. And really good leaders and really good organizations will start with why we want to do something, because that's the thing that ignites people's passions. He's very well known, but there's a guy in America called Simon Sinek, and he came up with this concept of the golden circle. And he says that all organizations know what they do. Some organizations will know how they do it, but the really successful organizations will know why they do things. And one of the examples he gives is Apple. And he talks about if Apple was an ordinary organization, they would have a marketing campaign that says, we make great computers, they're beautifully designed, simple to use and friendly. Do you want to buy one? What Apple really say is that they start with the why, and they talk about challenging the status quo, believing in thinking differently. They just happen to make products that are beautifully designed and user friendly, and those products just happen to be computers. So starting with the why, when you're telling a story, when you're wanting to get people to become passionate about a change that you want to make, is really important. Why are you doing it? What is your organization there for? What is the thing that gets you out of bed in the morning? What's the cause? In terms of the Hello, My Name Is campaign, the cause there was really very much about being treated as an individual, being referred to by your name, and not being felt that you were just the patient in bed 3. So that was the thing that really sort of ignited the passion there. Perhaps an inspiring example would be Martin Luther King didn't stand on the steps of the Lincoln Memorial and say, I have a project plan. He stood there and said that he had a dream. And this is the thing that very much captures people's hearts and minds. This why are we doing this? And if people can see that you are passionate about something, if they can see why you want to do something, then they are more likely to become involved in the change process. So going back to quality improvement and change, I would suggest that there are 2 ingredients to making quality improvement happen. And that is, yes, we need to understand improvement science and methodology, but we also need to understand the human side of change, because put the 2 together, we know, and there is evidence out there that shows that by doing that, we can affect change that not only happens, but is sustainable. So what have I said this afternoon? Well, I'd say change is a bit of it's a messy human affair, because change involves people, and people have fears and anxieties. They can become confused. They can become resistant if they feel the status quo or the norm or their world is being changed. But what we do know is that if we approach change in a particular way, that we can ignite people's passions, we can allay those fears, we can reduce that disorientation, that confusion that people feel when it comes to change. This is a book I read some time ago, and I'd really recommend it. And it goes into a lot more detail than I've done this afternoon. But it talks about behavior and about very much, as it says on the cover there, the human side of quality improvement, because at the end of the day, it's people that need to implement the change, and whether they do that rightly, wrongly, or not at all, very much affects its success. And this book really kind of explores that as a concept, and offers some really good solutions. So it's only a short sort of paperback, but I find it a very interesting read, and it's certainly something that shapes some of my thinking. So in terms of final thoughts, I think I'd sort of sum these up, and I think they're summed up very nicely here by Jim Smith, who's an operations and quality manager for Caterpillar in the United States. He very much talks about what I was saying earlier, is that the human side of change is equally as important as that technical scientific methodology side of things. He says that you can teach people change techniques, and kind of very much sort of, many years ago, I started to learn a lot of the change techniques that I employ today. But you can't really teach people passion. You kind of need to develop that. You need to tap into what people's passions are, and that's kind of very much really what the human side of change is about. It's about how do you ignite people's passion. And I think that is very much sort of the take-home message, really. Passion is kind of very much at the heart of sort of the human side of change. And if you've got that passion, you can do an awful lot. And I think those examples of Hello, My Name Is, MPJ Paralysis are really good examples of where the passion of individuals have been tapped into, and then this has developed into very much a social movement that's driven change. So thank you very much for listening. Apologies for the technical glitch at the start, but hopefully I've been able to share some thoughts this afternoon that you found useful.
Thank you, Vince, for your wonderful insight into the human side of change. So it is great to learn the factors which are important to address human side of the change are mostly responsible for sustaining the change in your organizations. So be it culture, context, co-production, active leadership involvement, sharing the stories of successes as well as failures, starting with why rather than what and how, addressing the heart and mind before the hand, that is, you carry out your activities. So you address the heart and mind first. Learning the tools, but as well as acquiring those soft skills in order to sustain the change and make your organization resilient. It was an excellent insight into the human side of change. So, there are a few questions in the chat box, so I'll try to present it to you one by one.
Do you want me to read the questions?
Yeah, no problem. Go ahead. I am able to.
Yeah.
You can.
So we have the first question, that is, how much change is driven by incentives?
I can only speak really, I suppose, from the perspective of sort of here in England and the UK. That, and I suppose it gives the older adage of what gets measured matters, and certainly there are a lot of incentives in terms of, say, for example, improving waiting times in emergency departments, as kind of waiting times for access to treatment, that very much drive a lot of the changes. Certainly the team I work in, very much a lot of the change that's being driven is very much around incentives to kind of improve performance. There's a strong regulatory element to the NHS, and the NHS is very political. So at the moment, there's a real there's a real sort of push on reducing access times to emergency departments and also driving down waiting lists. So a lot of the change at the moment is being driven really from the very top of government. So kind of I suppose the incentives there are to improve your performance. Otherwise, you do tend to kind of get a visit from the regulators, rightly or wrongly.
So we have one more question from Dr. Dinesh Baswal. Dr. Dinesh Baswal, can you please unmute yourself and ask your question?
So my question is, what are the initial indications that change has been adopted by the facility or by the organization? And how do we know that it is sustainable now?
Yeah, I think if you go around and talk to people, and certainly in my experience, it is that if a change has been introduced and it's kind of something that's very much been adopted, that if you go around and talk to people, they will talk about the change. So probably an example is in the work we do. We work with inpatient wards around reducing the length of time patients stay on wards, and we do quite a lot of work with individual wards around that. And we work with wards, and they come up with the change ideas which they implement. A really good acid test, a really good way to test as to whether an improvement has happened, is just to go onto the ward and walk around and talk to the staff, to see if they kind of understand why that change has happened. Are they using the language that of change? Are they using the language? Can you see it in terms of the actions that people are doing? So kind of, in some respects, it's almost that kind of initially anecdotal evidence of just going around and talking to people and observation.
Thank you so much, sir. Yeah.
One more question is asked here is, who adopts change faster, doctors or nursing staff? Interesting question.
Sorry, I missed that one.
Who adopts change better? So, whether it's doctors or the nurses.
Yes, nurses or doctors. It's really interesting. I think we talk about this very often, and it's I don't think it's a case of either or. It's kind of how you approach things. So, and I'm very conscious there are a lot of doctors on this, so I will not try to offend anyone. It's about how you talk to people. So we, in sort of the job I do, we can be having a conversation in the morning with the most junior member of staff in an emergency department or on a ward. And then in the afternoon, we can be sitting in the boardroom talking to the chief executive, the medical director, and the director of nursing and other members of the board. I think there's a skill there around sort of that sort of adopting how you talk. doctors very much, and you know, a few, excuse me if you feel I'm stereotyping here, but very much what doctors are very much, show me the empirical evidence. So if there's a really strong evidence base, you'll see doctors say, yes, we can kind of see that, we can, you know, we can sort of you know, adopt that change. I think nurses are very much in the hearts and minds. So kind of, it's more, you're probably leaning more to kind of towards that storytelling, but I wouldn't say it's mutually exclusive. I think that kind of nurses are equally want to see evidence, and you can tug on the heartstrings of doctors. So I don't think one adopts it sooner or you know, than the other, and kind of sort of very much. I mean, we as I said earlier, we ran a program, a collaborative fairly recently, and that was very much aimed at ward teams. So it was doctors, it was nurses, it was physiotherapists, it was occupational therapists, coming together to adopt change. I think it's less about who adopts it sooner and more about how you kind of approach the conversations. As I say, doctors are very much more, you know, if I'm having a conversation with medics, I very much probably lean more to talking about evidence. Whereas if I'm talking to nurses and probably allied health professionals such as physiotherapists and occupational therapists, it may be a little bit more sort of pulling on the heartstrings of people. So I think it's less about who adopts it sooner. I think it's more about the type of change you're trying to bring in, and how you approach that.
Okay, thank you, sir. So we have one more question from Dr. Amol Joshi. Dr. Amol, if you want to ask and unmute yourself.
Yes, good evening, sir. It was a nice presentation about the human side of change. One query is regarding internal motivation. So we all discuss about what's in it for me always, for the internal motivation part of it. Is there anything else, any idea you have tried or you have experienced which can work as internal motivation, except the idea of what's in it for me?
Yes, I think it goes back to what I was saying around the storytelling and creating a compelling narrative around why you want people to change, and that goes to that kind of hearts and minds. So one of the huge challenges the NHS is facing now, and it has faced for a number of years, are what are known as ambulance delays. So ambulances come to emergency departments and they can't offload the patients. So we end up with a lot of patients sitting in ambulances outside of the hospital because the emergency department is full. And the reason it's full is sometimes it's difficult to move patients that require beds in the hospital because discharges are not happening. So in terms of kind of approaching that, and I think this goes back to what I was just saying, the team I work with, we have what we call clinical associates. So they are doctors, nurses. We've even got, I think we've got 1 or 2 physios now in the team who are in practice and give us some of our time. And one of my colleagues will often present evidence around the harm that can happen to patients that spend too long in emergency departments. And as I say, I think that goes back to maybe kind of how you're approaching people in terms of, here is evidence around, you know, if the longer patients spend in your emergency department, you'll see increases in mortality. But equally so, looking at the, if you like, the hearts and minds side of things, a few years ago, we were able, very luckily, to get a family who had a relative that died waiting for an ambulance because the ambulances, a lot of the ambulances were tied up at the local hospital, and they very kindly allowed us to kind of make a video and include them in the video. You can find it. It's called Matthew's Story if you Google it, and it's quite a powerful story that says basically, this patient died because it took so long to get them to hospital, and it's a story. So actually using, if you like, hard evidence and that storytelling is kind of very much getting that message around. This is the harm that potentially we are doing to patients. So it's not what's in it for me as a clinician. Is it going to make my life more easier or better? And while that's really important, I think using methods that kind of say, well, actually, if you adopt this change, this is going to be better for patients, and that's a very strong motivator. So I think that's slightly different from kind of a different approach around what's in it for me. Hopefully that's
Yes.
useful.
Yeah, thank you, sir. Dr. Rajesh Mehta. Yes.
Thank you. My compliments, Vincent, for this talk, which actually Kedar did mention is one of the challenging areas in our work, the human side. So my question is that in the work culture, in at least in our part of the world, the system is quite hierarchical. And the second, obstacle is that it is also very genderized in a very differentiated manner. Our setup, most nurses are women, and there is a social imbalance in gender, equation. So these two factors operate in every health system in our part of the world, in our region, for example. So is there a shortcut to change that, or like NHS we know is a very egalitarian system, and here a resident cannot talk if professor is talking, and cannot contradict what professor has said, but there you have the equal right and liberty to speak. How much can that be a barrier in bringing in change and then sustaining it?
Yeah, I think it's a really interesting one. I think in terms of culture. I mean, the nursing workforce here in the UK is still predominantly women. As a nurse, and I've been in the NHS now for almost 30 years, and as a male nurse, if I'm in a room of nurses, you tend to find the males are still outnumbered. And even even in the NHS, there is this kind of almost there's still the sort of bit of a culture there. Sometimes we'll be talking to nursing staff on wards, and going to the sort of hierarchy bit, it'll be, oh well, we need to kind of get the consultants on board with this, and if we can't get them on board, it's not going to happen. They're the key to everything. So kind of it's a tricky one, and I think also there is a lot of, in terms of the hierarchy stuff as well. The NHS is very political, and you see, particularly when the NHS becomes under pressure, a lot of stuff coming down from the top of government. Our Secretary of State for Health is very much involved with some of the work that we're doing at the moment. So kind of it's a way how you kind of navigate your way through that, and how you kind of use some of those sort of approaches that I was talking about in terms of storytelling, building alliances, building relationships, finding your tribe. Who are the people that are like-minded, and kind of very much trying to sort of find those ways of sort of tapping into people, you know, whether that's using storytelling to kind of try and win some hearts and minds, or whether it's trying to present some hard evidence to say, well, actually, you know, what you're proposing, the evidence doesn't support that, so I think it's about trying to kind of find those tools to have those conversations. And going back to the change agency, it is very much, you know, you can be one person with one idea, but if you have the passion and you seek out the right people, you can become quite powerful. And we saw that in Kate Granger with Hello, My Name Is. Kate was a junior doctor. She wasn't a consultant. She was, you know, she's female, she was a junior doctor. And, you know, that was her experience. But what she was able to garner was some really powerful allies to kind of really push this forward. So I think the challenges are there, that, you know, in different in kind of different cultures. I spent some time in the States a few years ago, and, you know, the sort of healthcare culture there with insurance companies and you know, is kind of a sort of very different culture to the culture I've been used to working in the NHS. But I think it's about, you know, trying to kind of use some of those tools that I talked about to be able to kind of try and address some of those imbalances. You know, we often sit down with some kind of quite senior people within the NHS, and we'll have conversations to sort of say, you know, we know that there's certain things are a bad idea. It's just how you go and speak truth to power and tell those people that it's a bad idea. And sometimes it's about using that kind of human side of things and try to kind of have a bit of storytelling. And sometimes it's about you know, having some evidence to do that. So there are ways and means of doing it, and it's not easy. And I kind of do recognize that, you know, all over the world cultures are different, and how you approach it. And I think the States thing was a really good example. I happened to be over there in 2009, and Barack Obama had just assumed the presidency, and he was trying to bring in the Affordable Health Care Act. And really the opposition to that was tremendous. But what I learned from that experience was that America is an extremely conservative country, and that they saw that move by Barack Obama to be very much kind of almost a move towards socialism. So it really kind of challenged some cultural norms there. But as we know, Barack Obama was a very skilled politician. And I had the good fortune to be at an institute in Manhattan at the time. And we actually were given copies of a letter that he'd written to Senator Teddy Kennedy, who was quite powerful in terms of in the healthcare at the time. And when you read that letter, it was a very much an impassioned plea to hearts and minds. So even though he was facing this tremendous opposition, he was trying to find a way to reach out and to use his allies. You know, I mean, Teddy Kennedy was a very kind of powerful politician to tackle some of those challenges. So I think it's about trying to select your tools to have those conversations. Hopefully that's helpful in answering your question.
Thank you so much. Yeah, all levels need different treatment, but it can be done. You're right. Thank you.
Hierarchy we cannot eliminate, but to some extent we need hierarchy to drive a few things in the organization. But providing psychological safety and creating leaders at different levels probably is the answer for countries like us, maybe. So, Vince, one question I have is, are there any tools or methods to address this human side of change in our day-to-day practice?
Um, yeah, it just goes back to that talking to people. I think one of the things I think where I mean, change evokes a lot of emotion in people, and you know, people will resist change for all sorts of reasons. They'll sabotage it or whatever. One of the things I always try to do is just be curious. So if you're hitting up against a kind of, you know, a resistance to change, is just have a conversation. Just try to find out from people what their concerns are. And actually that opens all kinds of doors then, because you can start to understand why people are behaving the way they're behaving. But also you start to build relationships then, and you can build relationships with the kind of the most unlikely people, because just being curious, you're listening to them. You might not agree with what they're saying, but actually they're feeling listened to. And also you can then start to kind of have conversations. Well, you know, what are your ideas on this? And then suddenly you're drawing out their ideas. They're starting to feel involved. And I think it goes back to that kind of, if I came along with you with an idea and said, I want you to implement this idea to reduce the length of stay on a hospital ward, you're going to be like, yeah, you know, who's he coming here telling me what to do? I know best. And then I'm going to be sitting in the boardroom saying, I can't understand why those clinicians haven't bought, you know, why haven't they bought into this idea? Whereas if I come along to you and say, we've got an issue with length of stay, what we want to do is X, what are your thoughts on it? And you come up and say, well, here's a potential solution, can we try it out? And I say, yeah, go ahead, do it. It's your idea, you've invested in it. So you're more likely to kind of make that idea happen and sustain that change, because it's your idea, you've invested in it. I haven't come along and told you to do something. So I think, you know, one of the most powerful tools, I think, when it comes to change is talking to people and kind of understanding where they're coming from, but also explaining to them why change is needed, but not always giving them the solutions, just kind of explaining and then sort of saying, any ideas? One of the things that we say, and we work with some very challenged organisations, and as I said, the NHS in England is very political, so that if you are a very challenged organisation, you tend to have a real spotlight shone on you. You get lots of visits from lots of important people that think they know all the answers. And when we go in, one of the first things we say is, we're here to help. You know, what help do you need? We're not here to tell you how to do things. We're just here to help. How can we help you? So I think it's that conversation with people, being curious, trying to understand their perspective. You know, and I've seen some real kind of, you know, I've sat in a meeting and there's been some real opposition to things, but then, you know, 6 months down the line, that individual is probably the strongest advocate of what you're trying to do, because they felt listened to, they felt that they've been involved in what's happening. So I'd say talking to people is a really, it's an easy thing to do, but so at the same time it's a hard thing, because it's, when you say talk, it's about communication. So actually it's more about listening, asking the questions, and then listening and responding to what people say.
Communication seems to be the key in addressing human side of change. One of the ways which I found useful in my setup was team huddles, a short 10-minute huddle in the morning hours. And that really worked very well in getting better buy-in from the people to voice their concerns, queries. So that was very useful. So one more question is, Is change in any system more sustainable if we focus on gaps or existing strengths?
Yes, that's an interesting one, actually. I was talking to some colleagues this morning about this. We're doing a piece of work at the moment across England with 15 hospitals that are very, very challenged, and it's very so I keep using this, but it's very political. It's something that's very much coming down from, well, it originally started with the Prime Minister's challenge, so that's kind of, you don't get much higher up than that, really. But those organisations were asked to come up with plans around how they were going to improve, and we looked at those plans because we wanted to draw some themes out of it. And one of the strong themes that came out of it was workforce, and they felt that they had gaps in their workforces that made it really difficult to kind of move some things forward. But also, one of the things that we noticed was that they had got some really good ideas and really good people in their organizations. So what we're trying to do with them is we're trying to kind of, through the workforce side of things, is we're trying to kind of get them to think about what are the gaps in the workforce and what are the best ways of addressing those gaps. But also, as organizations, they have got a lot of strengths. So one particular organization I'm working with, we had a call yesterday with them, and they've got some gaps, they've got some good ideas in terms of plugging into their workforce, but they've got there's a real strength there, that they've got a lot of clinicians. And when I say clinicians, it's predominantly doctors and nurses who are willing to try a particular different way of working, and that's got strong support from both the nursing and the medical workforce in that particular organisation. So actually, that's a real strength that they can build on to kind of make a change that will help them as an organisation, and that's quite an easy thing for them to do, because they've kind of got the resources, and they've got they've got those clinicians that are willing to try it. So they're going to press ahead with that, but equally they need to fill those gaps in their workforce as well, because if they don't, they're not going to make some of the changes stick. But certainly in terms of some particular changes, they will definitely be sustained because those clinicians want those changes to happen. And I guess that goes back to what I was just saying about the ideas have come from the clinicians. They've got the ideas, they've invested in the work in that. So I think it's a little bit of both, really. I think you do need to address your gaps, because if you don't, you're always going to have those obstacles to kind of some change happening or some change being sustained. But if you've got strengths within an organisation, build on those as well.
Komal, any questions?
No, sir. So I think we have covered all the questions as of now. And thank you so much, sir, for answering all the questions. And so before leaving this session, I request all the participants to please fill the feedback form, and this feedback form will be directly linked to the certificate. I have shared the link in the chat box session. So I request all the participants to please fill this feedback. It will take around 5 minutes only. So you can either scan this QR code, or you can just directly click on the link which is available in the chat section. So I'll hold it for a minute. I request you to please scan this code or click on the link for the certificate.
So Vince, it was wonderful to have you today for this session on human side of a change, which is often a neglected area while we train people in quality improvement. But it is the most important aspect of quality improvement. So we learned that communication is the key when we want to address the human side of change. And as leaders, we need to be vulnerable, curious, and instead of providing solutions, we need to ask questions. So that's how we can address this human side of change. It was really a great insight into this area of quality improvement. So thank you very much.
Thank you. As I once again apologies for the slight technical issue at the beginning there. I have sent my presentation through. If you haven't received it, let me know and I can resend it. But
Sure.
yeah, thank you very much for inviting me along. Hopefully it's been useful.
And
thank you so much.
To all the participants for actively participating and interacting. So it was wonderful to have all of you here.
Yes, so some participants have some issue with the link. I'm sharing the link again. So there is a small announcement in between that NQCN is organizing the in-person POKI workshop, that's Point of Care Quality Improvement Workshop at New Delhi. And I'm sharing the registration link for the same in the chat section. Those who are interested and can be available in the POKI workshop, which will be held in New Delhi. So please register for this workshop as well. Yes, I'm sharing the link for registration in the chat section. You can register for the POKI workshop. So thank you so much, everyone, for joining and taking time out of your busy schedule. So yes, Dr. Kedar, any comments? Dr. Praveen?
Dr. Vikram is there? Praveen?
No, thank you. I mean, you can close the session. Thank you.
Okay. Thank you, everyone.
Thank you and good night. Thank
Good
you. So Vince is very active on Twitter. You can follow him. So he tweets very regularly and very useful articles, many of which I post in our groups, WhatsApp groups. So today only I have posted one which Vince has tweeted. So wonderful article. So thank you, Vince.
Okay, thank you so much.
Thank you. Goodbye.
Bye.